our speaker is Dr. Santiago Neme. He's a medical director of UW Medical Center Northwest Campus, also the senior associate medical director with UWMC, and he's a clinical assistant professor of medicine and infectious diseases. And so we have a list of frequently asked questions and general information that we will go through, but of course, at any time, if you have any other questions, please feel free to enter them in the chat and we'll try to get to them during this 30-minute session. So with that, I'll turn it over to Dr. Neme. We can start off with some of the FAQs that we have.
Great. So good afternoon. Thank you, Chantal. My name is Santiago Neme. I'm an infectious disease doctor here at UW. I work both at UWMC Northwest, Montlake, but also Harborview. I see patients at the Madison Clinic there, the two West clinics. So I thought I'd start with some of the general aspects of the vaccines that we currently have available at UW Medicine and also in the US. As you know, we have currently two approved vaccines. One is the Pfizer vaccine and the other one is the Moderna vaccine. They both are pretty similar in that they utilize mRNA, which is basically a genetic code that then gets placed in this kind of lipid droplet or like fat droplet that it's kind of the envelope for the genetic code and then gets, administered to the patient. And the idea behind this is this genetic code obviously is not COVID. So this vaccine cannot cause COVID to folks. But this genetic information then gets to the cell and it really sends signals to create a COVID-like structure that then we build antibodies against. So the idea is that we're mimicking COVID without really having any COVID in the vaccine. These two vaccines are highly efficacious. That means that their ability to prevent COVID with symptoms is about 95%, which is extraordinary and amazing, really. I wanted to say that as you might have heard, these vaccines were studied in their effect in preventing symptomatic COVID, that is COVID that has symptoms. Vaccines are typically studied that way. We still don't know whether the vaccines would prevent you from transmitting COVID if you happen to get infected and without having symptoms. So that information is forthcoming, and this is one of the reasons why we still want you to continue to mask and socially distance even after completing both doses of vaccine. So that's an important point. We also do not have the vast majority of the population really vaccinated, which again highlights the stress on really continuing to mask and social distance. I also would like to say that these two vaccines have been studied in over 70,000 patients. They are extremely safe, both of them. And I also wanted to comment on some of the reactions. We expect these two vaccines to really be reactogenic, meaning create a reaction within the body so then we can build that immune response that we're seeking. That being said, I would like to distinguish what it is an allergic reaction from an adverse event or an adverse side effect of a medication or vaccine in this case. We've seen that through the data of now in the US, we've vaccinated over 20 million people, and we've been collecting information, and what we've been seeing is that these severe allergic reactions that have been prevalent in the media often occur within 15 minutes, and most of them within 13 minutes of the administration of the vaccine. And this is what has led to the observation of 15 minutes for everyone getting these types of vaccine to make sure that there's no severe reaction. These severe reactions have been very infrequent. And then what most folks who have some side effects, which is different, they tend to experience more local pain at the site of infection. A subset of folks, including me, have had kind of a more robust reaction after the second dose, where I felt fatigue and aches and a headache and a low-grade fever for 36 hours after the second dose. That's more common in folks who are younger than 55. I'm 45, and the data has shown that this is kind of more prevalent in folks, and folks who are even younger than me would have oftentimes kind of a slightly higher fever or more fatigue, etc. But the magical thing about this is that it really lifts off pretty quickly after that. So I went from having symptoms or discomfort associated with fatigue, for instance, to feeling completely normal within 48 hours. So again, I just wanted to let you know that we expect some reactions. We expect at least local pain at the site of the injection. Some of us can get some more symptoms within 48 hours of the injection. That's not something to be scared about. I also want to say that if you happen to feel only the injection site and no symptoms, that doesn't mean that the vaccine is not effective. So just know that as well. The vaccines both of them are 2 doses. I would say the only major difference is that the Pfizer vaccine is approved for patients 16 or older, whereas Moderna is 18 and older. One key question that comes up is that if you've had adverse reactions in the past or allergic reactions in the past, we want to ask you that information and have a discussion with you. For instance, anybody who has had a history of anaphylaxis due to any vaccine, then we evaluate those folks and we actually observe them for 30 minutes. As opposed to 15 minutes. The only really contraindication to the vaccine is whether you've had a reaction really to a known ingredient of the vaccines, which is different from having a reaction to something else. So you want to have specific information about what you reacted to in the past, and that's going to be important. And that's something that you're going to be asked and assessed. I also wanted to highlight the fact that you cannot get COVID from the vaccine. The second thing is that if you've had COVID, there's no biological reason why you cannot get the vaccine as soon as you're recovered. But because the vaccine supply in general in the US and the world has been somewhat limited, and we know that folks who have had recent COVID within the past 90 days have some protection against new infections, we would like to prioritize the vaccines for those who actually are more susceptible to the infections, that is those who have never had COVID. Therefore, we ask you, if you've had COVID, that for for 90 days, you do not get vaccinated and maybe do it, and definitely do it after the 90 days. But there's no biological reason why you couldn't do it as soon as you're recovered. We've had one case of a person who unfortunately got exposed to COVID the day before the first dose of the vaccine and then developed COVID. And we were able to give him the second dose at 3 weeks as soon as he was recovered. So again, these are case-by-case situations, but biologically, there's no reason why. We just like to use that information in terms of the priorities. And the other piece that's general, I would also like to point out the questions around pregnancy. As any intervention in medicine, we always weigh risk and benefit. And although we have a lot of safety data on the general population and the studies, those studies did not include pregnant or lactating women. So that's something that you should know and you should discuss with your patients. But we generally think that the vaccines are actually safe, but we don't have the scientific data to say that pregnant women have been studied. So it becomes a question of risk and benefit, where you might have a pregnant patient who is a provider, who is a nurse, who is exposed to COVID, or someone who is delivering mail who will be exposed to other people at a time where community spread is pretty significant. Then you have to weigh the risk and benefit, because we know that if you get COVID and you're pregnant, then your risk for severe complications is much higher than if you're not pregnant. So it's all about risk and benefit. Anecdotally, I could tell you that a lot of my pregnant colleagues who are actively seeing patients and working in medicine and are opting to get vaccinated. But I would really encourage anybody who's pregnant and would like to discuss this to really talk to their doctor and see how they can address their specific situation. Those are kind of the general things that I thought we could start by covering. The other thing, the last thing, and it's more last minute, is that we have put together at UW Medicine a pretty significant infrastructure to really deliver the vaccine, administer the vaccine, and making sure that we're doing this through an equity lens. At noon, we had a session in Spanish that I led to make sure that folks who don't understand English as accurately, as precisely as folks whose English is native or primary, that they could get access to the same information and then make informed decisions. There's one factor that we do not control, which is the amount of product, the supply, the vaccine supply, we do not control. So whether one day we're offering Pfizer versus Moderna, whether one clinic flips to the other, whether some appointments get canceled at some point, it's really not up to us. It really has to do with the supply that we get from the state and obviously the federal government. And kind of last minute, I wanted to share with you that it seems like the Johnson & Johnson vaccine, which is a one-dose vaccine that doesn't require any freezing, will be presented to the FDA within the next 10 to 14 days, according to Dr. Fauci's interview a couple of days ago. That's really reassuring because we will not only have 2 vaccines, we will have a third and possibly and likely a fourth and so on. So the idea is to really have more vaccine, more options. Thank you. So that concludes the kind of the general piece, but I'm happy to entertain questions.
One question that would come to mind is with the mention of the Johnson & Johnson vaccine is efficacy. And what does that mean? Because Johnson & Johnson's, for some of us that have heard, it's in the 70s efficacy versus Moderna and Pfizer, which are in the 90s. So if you can talk more, explain more in plain language what efficacy means, and if Johnson & Johnson comes, if and when it does come on board, is it still a good vaccine to take if I don't have any other choice?
Right, absolutely. So the thing about efficacy is really the ability of the vaccine to achieve the effect that you're looking for. In this case, is really, can the vaccine prevent symptomatic COVID, and can it prevent death from COVID? And these 2 vaccines are highly efficacious. Now, the Johnson & Johnson data, the phase 3 data has not been published yet, but what we know is that when they did analysis on neutralizing antibodies, they found that they were likely to be highly efficacious. I just don't know the threshold, if it's going to be 70, if it's going to be 90. What I can tell you in general, that in infectious diseases, when we talk about vaccines and we talk, for instance, the flu shot. The flu shot is typically between 50 and, if it's a good one, 55% effective, right? And the flu vaccine has been effective in a way, or successful, because the massive distribution, right? Because you're cutting the risk significantly, right, if you do it. So it's all about scale. If the vaccine is 95% effective, but I only give it to 10% of the population, that's not a good thing. I would rather have a vaccine with slightly lower efficacy and I give it to everyone. We're going to have a better shot at battling this. So I would say, don't get disappointed if you feel like the vaccine, if we hear that the vaccine is less effective than Pfizer. Pfizer and Moderna, I mean, those numbers no one could even dream of those efficacy numbers. And we're going to continue to aim at having that high efficacy. But the truth is that we need a huge supply of multiple different vaccines that are safe to be given to anyone, anywhere, and really anywhere in the world, right? So we still don't know the efficacy of the phase 3 trials, but the amount of neutralizing antibodies for the Johnson & Johnson based on the phase 2 trials were reported by press release to be really exciting. We just don't know until the FDA sees the information and data. We just won't know. Yeah, so there's a couple questions on the chat. Yeah, there's an issue around supply for sure, and we're living that. And what I could say is that it's unfortunately an area that UW Medicine does not control. So all we could do is set up our infrastructure, be ready. Like UWMC Montlake is giving 860 shots a day, which is insane. It's amazing, right? So we're ready. We're doing it. The question is, are we going to continue to have this type of supply? And there's it's kind of a moving target, and it changes every day, and we continue to assess it. We also don't know about the lowest age for the Johnson & Johnson. Like we still don't know about, and this is what I said is that it's going to be submitted for FDA review, but the data is not published yet. The new variant, yeah, so I wanted to comment on the new variant. So the new variant, the B117, is the variant from the UK. And what I can share with you that the reason we know that we have the variant in Washington, it's really because of our lab. Our lab has been doing surveillance, has been retesting samples everywhere, like thousands of samples. And this is how they picked up they identified this. Our lab was not only involved in the Washington discovery, but also Oregon and California. So it helped pick up the variants in these other states as well. And what we know about the variant is that it's more transmissible. There's some reports that it may be more fatal, but that hasn't been proven yet, because we need to talk about, is it worse because more people are getting infected, or is it because Chantal and I get COVID, I get B117, and she gets the current more prevalent strain now? Does that mean that I'm gonna be more likely to die from her? We don't know. And the UK has reported some informal data saying that that might be the case, but we don't know yet because we haven't seen the data. But what I can say is that it definitely seems to be more transmissible. And this is why it is really important for us to continue to mask and continue to do our physical distancing, because we know that those tools work. And we know that the virus is not going to be jumping from face to face, like across all the barriers and the distance and everything we're doing, right? So we know that biologically, we need to continue to do the things, even as the county rates come down, because we're seeing fewer patients. We have fewer patients at UW Medicine with COVID. The King County has fewer patients. The positivity rates are coming down, but we need to continue to do our social distancing, all the things that we've been doing to continue to control this, because the idea is that you almost have two things, right? It's kind of a race. You have this virus that has variants, and then you have the vaccines, and you need to get more people vaccinated, right? And you need to have folks continue to wear masks. So Pfizer, Moderna, there's not a lot of data about differences between the two. This is why we don't pick one or the other right now. You'd be surprised, because some people start creating, oh, I got Moderna and this is why I got sick. No, it may just be that because people who get Pfizer also have the same symptoms that I had, right, when I had the second dose, which is this very transient fatigue, 36, 40 hours, and then I'm fine, right? So I would say the good thing is that we have tons of data. What I can say is that Moderna has published that out of like 4 million doses, these severe allergic reactions always happen within the 15 minutes. And this is why observation is key. And this is why we would never give you a vaccine. And even if it's a drive-through, we're going to have to keep watching you while this is happening. And when will we have COVID vaccines? There's several studies around children. One good thing about children is that the data from schools seem to point towards, there's a big German study that came out that seems to indicate that children get COVID from their parents, right? So the question is, so most infections are from adults that get to children. And the question is, can we make a significant difference by vaccinating the parents and the teachers and the adults around these kids, right? So so that's something that that we're going to have to continue to work on. Ideally, it would be great if we could also, and we're going to get there, vaccinate children. But when you look at the data, it's somewhat reassuring that you see that most of the infections in Germany associated with schools had nothing to do with the source being the kids. It was really by their parents and the adults around these kids. Yeah, Trish, I don't know about the difference between the, I honestly, we don't know that much about the J&J yet. I wanted to give you an idea that it's coming, but we don't have the data yet around the preservatives and all that, but we're gonna be bringing that to folks. We're gonna be discussing it at the town hall as soon as this information is known. Yeah, it might have more preservatives. That's a good question. I just don't know. I'm going to ask Dr. Denaretti, who is obviously an expert in this, if she has more information on the J&J product.
One question, talking about the different vaccines that are coming out, and now that the government has opened up to the community for the 1B, those that fit the 1B category, you know, and I think Martine can attest to this. We've been at several community influencers at their entity meetings, and some of the feedback has been from the community that they're really adverse to getting vaccinated because there's this rumor that it will change your genetic code or alter your genetic code. So I'm sure a lot of us that work at direct patient care at the bedside or in the clinics, that they may be getting the same response from the patients. How can we combat those myths and encourage patients to at least consider getting vaccinated?
Yeah, no, thank you so much. For something to modify your genetic makeup, it really has to impact the nucleus of the cell, right? It has to be incorporated. And this is not the mechanism of these vaccines. So there's no concern around that. The vaccines help the cells create this protein that mimics the SARS-CoV-2 virus, and then you can create a membrane of protection around that, which is the antibodies, right? And when you encounter the real SARS-CoV-2, you tackle them, you neutralize them. But the vaccine has no possibility of modifying your genetic code per se.
Yes, I'm looking at one question. Yes, we can share the link. I'll put it in the chat. Another quick question is, seeing on the news and hearing about low supply, and say I got the Pfizer vaccine and I'm due for my second dose and this place has Moderna, can I mix the vaccines, the first?
Well, that's a good question, and it's a moving target, because a week ago I would have said no, we don't mix. But CDC has just come out with some guidance that if it's essentially if it's absolutely necessary that you cannot get the same vaccine, there are very exceptional circumstances where that can be considered, where you switch from an mRNA vaccine to another mRNA vaccine. I don't see this changing from Moderna to J&J, which is a different mechanism, right? But Pfizer and Moderna have similar mechanisms, so that would make sense. But again, in exceptional circumstances, we would consider it, but this would be a case-by-case situation. It will probably be assessed by Dr. Dinneretti to make sure that we want to do that. It is in the CDC guidance that has just come out, giving some flexibility. The other thing that happened in that review is that we were saying that, you know, for Pfizer, we would do 3 weeks after the first dose, Moderna 4 weeks after the first dose. But now there's an extension of that to 6 weeks. The UK has been doing 12 weeks, but CDC says it's okay up to 6 weeks to wait for that second dose up to 6 weeks. This is not what we're doing at UW, but I just want to say that it biologically makes sense that you can spread them a little bit, so that's coming up as well as something that's changing. But our methodology here has been to do 3 and 4 weeks, or actually we're trying to consolidate to 4 weeks because it's kind of easier.
Thank you. We have about 3 minutes left. I don't see any questions in my chat. I don't know if anyone posed any more questions to you.
There's when supply picks up and J&J is available, do you anticipate you guys still providing mRNA as a choice given the storage expense issues with mRNA? Honestly, I don't know. We need to learn more about J&J. If J&J is equally efficacious and there's no contraindications for certain groups, it may be that J&J is more the vaccine for kids. We just don't know. But knowing UW formularies, we're going to do a risk assessment where we look at the efficacy, the evidence, the price, all of these things at once, and our ability to really vaccinate the whole population, because the idea is to really provide this to the public and improve the health of the public, which is one of the missions. We're seeing in EPIC that patients are only allowed to schedule first dose and can't schedule second dose until they receive their first with limited access. They got, she's getting Elijah. What's the max? Yeah, I was just mentioning that UW, I was just saying that CDC has relaxed that gap or interval between first and second dose to 6 weeks. So it's something that we'll continue to evaluate. Great. Okay, well, thank you so much, all. And we're going to continue to do these. Please stay engaged, get vaccinated. It's something really great, but it doesn't mean that you can, you know, put your guard down. We need to continue to fight this. And please have these conversations with your staff members, with your friends, with your family. Anybody who's eligible for the vaccine needs to have the information so they can choose to get vaccinated, which is the only way we're going to tackle this. So thank you so much.
Thank you, everyone. Thank you for joining us today.